Let's try to launch.
Okay, go ahead. I've already read the first part, which, let me just read this again in case anybody joined late, or not late really, but just everyone, I need to remind everyone this meeting is of the Behavioral Health and Wellness Advisory Council and is a public meeting and is being recorded. Please mute your microphone except when you are speaking. There's only one agenda item on our agenda today, and so our conversation will be confined to that. We've taken roll. So we have everyone accounted for in the meeting. So I'm going to turn it to Bob at this point. Bob, I'm going to mute my microphone and see if it'll help.
Okay, thank you. And if I start breaking up, somebody just let me know that. But again, with our apologies for the technical difficulties today, and always with our appreciation for everyone taking the time to join us, especially 2 weeks in a row here. Somebody made reference to a 3-hour meeting today. This is surely not intended for 3 hours, and actually the hour and a half we had set aside, we were hoping not to use that, but we've already used 45 minutes of that time. So let's be as efficient as we can, but also let's take the time we need to finalize these recommendations, right? So our goal today, again, as it was last Monday, was we got together last week. It was to work together in a responsive way to meet the mayor's ask for recommendations, funding recommendations to address healthcare, to address behavioral health care and wellness needs in Davidson County, specific to COVID-19. The work, Dia, and again, just on behalf of all of us, thank you for pulling together our conversation of last week into the template that you have. It's I've heard, it's really well organized. It's helpful that you captured everything thematically, as well as indication of the gap, the populations, the solutions that we all discussed last week, and then took it that next step and gave some thoughtful consideration as to where the potential source of funding is, right, with regard to each of the solutions that we've recommended. So our task today, and we surely hope everyone has had a chance to read this prior to today. Dia, thank you for sending this out late last week. But we need to look at this today, make sure that we have identified those system gaps, especially now that we've had a chance to look back, whether look at the system gaps, the populations, and or the interventions that have been captured here. Most of our work took us to 3 areas, right? We focused last week on crisis. We focused on child and youth services and seniors. Those seem to be the emerging 3 core populations, as well as our acknowledgement that there were other isolated populations that needed our attention as well. It's that conversation last week that really informed this document. So I don't know that we can go through it just generally. I don't think we're going to go through every item here, but maybe if we can just take major item header, like one, for instance, really trying to stem the tide of rising fatal overdoses. There's, right, the gap recommendations here are for crisis and detox services. You can see the population solutions identified. I think if we just maybe take each Roman numeral, I think they're not numeric, another Roman numeral. If we just focus on that Roman numeral area and see what feedback we have to that area, whether we're good to go with what we have or whether there needs to be modifications in any one of those areas, right? A modification, the gap, the population, or the solutions and interventions. Following today, we'll launch that in a second. We'll spend some time trying to quantify what we think the dollars are associated with each of the solutions or interventions recommended. We want to make sure that each of our solutions has a price point, so that as COVID funding becomes available, at least some dollars can be allocated to hopefully one or more of these areas. But we definitely want to send a recommendation with a dollar amount as well. And then we want to get all this, again, to the mayor as quickly as possible. So that's the plan from today. The work of this committee today is to review this. We really need a thumbs up if we're ready to go, thumbs down if we change our mind completely, or some recommended edits as we go through this. So if we look at Roman numeral 1 and the crisis, care, and detox gap, any comments there for this group? We good to go?
Well, this is Mary Linden. I wouldn't want to change anything, but I would just put a little asterisk on it. I have a statewide meeting tomorrow about how to bridge some of the gaps in care and respond to the new spike in overdoses. And it will likely include some, develop some new information. So can I just get back to you guys with anything more that we end up pinpointing?
I think that would be helpful. And then for this group, what we can always do is send that out and make sure there's agreement on the group, right? If we're going to end up changing something here or adding something to this list.
Mm-hmm.
Yeah, it might be easier on this call too, that I'll take silence as, as agreement. And if you disagree, then please come off mute and indicate, right, a further suggestion or disagreement. So Mary Lynn, you should be able to get back to us by end of business tomorrow, maybe noon Wednesday. Would that give you enough time?
It definitely would. We're putting together a pretty action-oriented plan, so yes,
okay.
Should be.
All right. How about if we say noon Wednesday, if that gives you sufficient time?
Happy to do that, yes.
Okay, thank you.
This is Jeff. This looks pretty complete. I would just add under population that this would also apply to those who are homeless, just so we're covering all the bases.
Thank you, Jeff. Good catch. All right, so that'll be a addition to the population under Roman numeral 1 at homelessness. And then Mary Linden will get back to us by noon on Wednesday if there's any additional feedback in this area. And again, since the group will not have had the benefit of vetting that, we'll send that out quickly for council's reaction. Roman numeral 2, investing in the rebuilding of routines for children, youth, and families, connecting the healthcare, structure activities, daycare, right, promote social, emotional, mental, physical health, and well-being.
Bob, this is Katina. Can you hear me?
I can.
So I think this is great. My only question or concern is letter G, the digital divide for low-income families. If this is a specific population that's not already served by metro schools, since they are also issuing laptops.
Good question. So who might be left out?
Correct.
Yeah. Will we be able to identify those children who will not be getting access to laptops, hotspots?
I am not sure about that.
Yeah, because my assumption for our conversation here is we want to capture, we want to include obviously as many children as we can. We know that Metro is working actively on that solution. So maybe we need to be clear here that let's see where we could add that. I don't know that this is, as I'm looking at this, I don't know that this is limiting only to those children. We can change, obviously we can address that in the solutions to make sure we're talking about ensuring the same level of hardware, software to children outside of. So would this include our charter schools?
I think that's.
Whoever said that broke up.
I'm sorry, this is Sheila Calloway. My understanding is the Metro did receive the funding to make sure that every student in Metro, which would include charter schools, have access to laptops. That would not, of course, include private schools. It theoretically should include homeschools, because homeschooling is also part of Metro. It's under Metro's purview, I guess. So I'm not sure if the money that they got to hand out, I think it would include everybody that's in a school other than private schools.
Again, since we don't want to spend the time to wordsmith this, I've got a note on that. We'll go back and look at it. Our goal here, right, as a council is to make sure it is that inclusive and there's no limitation here within the purview of the Metro school system. So homeschooled and charter, let's make sure it's inclusive of homeschooling charter school. All right. Are we good then on Roman numeral 2? Any other comments on any of the populations or the gaps defined under Roman numeral 2?
Bob, I could just make a comment. This is Jameson. Wanted to make sure that we see the benefit of telehealth and being able to create the versatility and engaging our patients and families during this time. Just in the spring when we had 0 school days, we were able to engage with over 1,000 patients and families per month within Metro using that resource, both telephonic as well as telemedicine. So the model and the resources exist. It's just a matter of making sure that it doesn't expire within TennCare, particularly before we move into the school year. So coinciding the plans for the fall, which are tenuous at best, and our telemedicine policy is going to be very important. So it's not an issue of having to reinvent a resource. It's just a matter of advocating to make sure that we have those resources in place.
Okay, and we can address that under D as well, can we not, under the digital divide? Or actually a separate area on maybe a policy, continuation of current flexibility.
Right. It's part of that point about deploying the clinical staff to address the emerging issues. I think that's a key component. The way that we deploy is partly by that telemedicine during this critical time.
This is Mary Linden, and I don't disagree with a thing that Jameson just said, but I do think it's important to note to all of us, maybe not necessarily in this plan, that access to telehealth has always been critical and has been a big barrier that we've finally broken through to be able to get that in TennCare. I would not want it to go away. However, I will tell you that one of tomorrow's talking points about the increase in overdoses is going to be about the fact that there's a whole lot of people being put in telehealth for whom, residential treatment and other options are not available. And, we can't put everybody in telehealth. Just there does need to be access to all levels of care that meet their individual needs. So just wanted to say that out loud. Telehealth is a great resource, but I'm a little nervous that we're going to expand it to the point that we forget that there's other levels of care that are actually more applicable to people's needs as well.
I absolutely agree. Yeah. As we've seen the importance of really personalizing based on the needs and preferences of our patients and having both capabilities to ensure that we have access in this really difficult time is going to be a key component. So I completely agree that there are limitations but there are absolute benefits and a system in place to support those patients.
We're looking for expanded access, right? We surely don't want the traditional way of delivering care and this new opportunity right within telehealth to be conflictual. We just want to make sure that we recognize that telehealth, and Mary Lyndon, you said it, right, has opened up additional access. It's not appropriate for everyone in every situation, but we ought to be able to have access to telehealth services inclusive of the new flexibilities, right? Direct to patient is critical. So we don't have patients driving to licensed facilities. I mean, it's a bit ironic. And that we're currently being reimbursed for telephonic as well as televideo. And that recognizes the fact that not everyone has the same level of connectivity nor the same equipment. So again, we want to keep all doors open. And I think, Jameson, good reminder. I think as much as we've talked about it, I really thought it was in here, and I say, if it is, it's inferred. We need to be really clear. Right about maybe all three of those points, and we'll add that.
And two aspects of that. One is the timeline. The end of July is right now where that telemedicine or that TennCare policy is restricted, and so that is just a critical time that we need to keep on the radar. The other aspect is the fact that our spaces are so constrained now because of the distancing needs that we need to put in place, and so often our groups and our therapy options are limited in their capacity in person, and so that telemedicine enables us to expand beyond given the distancing issues within the confined spaces that we have. So those two components make it a unique challenge to ensure the same access to care before the crisis.
Right. Well said. So with that modification, I'm hearing then that every item, right, the identified gaps and the populations, solutions offered under Roman numeral 2 will be good to go. And again, we'll send out these modifications. Moving on then to Roman numeral 3, where we're talking about the senior population and other individuals, families, right, groups isolated at home. So there's transportation issues we raised here, the need for virtual communities for support, also recognizing, right, that social isolation and loneliness, have been, right, indicators of poor healthcare outcomes for quite some time. So we recognize that as a provider community. We recognize that as researchers, and we want to make sure we're keeping that right front and center in terms of people's attention as well. That's why we've come up with loneliness. And we may change that to loneliness and social isolation as the gap, and then obviously access to non-stigmatizing information. I don't know, did Judge Eisenstein able to get back on? I know the judge was reaching out for some additional information. I think we're still waiting for some of that information to come back. Angie, who was that contact specifically? I know I have to go back and look at some notes.
This is Robin. It was something he was following up on, I had mentioned, which was the area counseling on aging and disability.
Yes.
His contact there was great.
Okay. Yeah, I don't think we have all that information back.
I have, yeah, and I can send him.
Okay. So any additions to 3?
I apologize for not having been part of the earlier discussion. All of this is in relation to COVID, but I would think for seniors in particular, I've heard of a lot of seniors who are not willing to participate because of a lack of personal protection equipment. So is that something to be addressed specifically here?
So we're talking about providing reliable and clean transportation. The bad echo now.
I recognize it's an issue really for everybody. Maybe it's just a given. But, you know, I think for seniors, I just hear about that issue much more often coming up, that they don't want to go into certain situations because of their fear of COVID.
So a general comment here about ensuring that seniors have adequate PPE for all of their health care. So we're talking about their health care visits. You know, in most cases, right, most healthcare providers today are requiring patients to have masks. If they don't have their own mask, they're being provided a surgical mask. I know that's going to, depending on what happens, right, with our continued increase in positive COVID cases, that again could create a shortage of PPE. Are we recommending, again, I'm hearing what the issue is. I'm not sure what direction we're going. Is it ensuring adequacy about PPE? Is it education?
I'm kind of making some assumptions here, but I do think in some respects it's education, because they need to understand how those things will keep them safe. But I'm also hearing that many of them lack access to what they consider to be appropriate, you know, masks, and so because they don't have the education to know what is safe and they don't necessarily have an item that they consider safe, they're not going out. So I think it's both.
So Mary Lyndon, when you're saying that, I'm wondering if they're missing, and I'm getting such an echo, on essential care, physical and mental health care, because of their fears. And I'm wondering if some kind of education or with providers, just some kind of having them make sure that they're working with those clients to reassure them.
Yeah, I think if they have that and they had some reassurance, for example, that the van that's picking them up has been cleaned, you know, after every trip or whatever it would take. I don't want to get into the weeds too much, but I do think it does require some reassurance and education.
Well, I'm thinking primarily doctor's offices. I think they're afraid to go into a medical setting because of exposure, and I think having doctor's offices, maybe, I know they're doing the calling, I know they're doing the protocols, but somehow educating seniors to the fact that this is going on and they should not miss important medical and behavioral wellness appointments.
Is this another PSA opportunity, maybe?
Possibly. I think it's something that, you know, it's a PSA opportunity. I think we can make the general practitioners and other doctors who are going to do the screening for some of these behavioral health conditions. But I think we can screen. I think we can do a PSA to them to encourage them to reassure the folks coming in. Maybe they make an extra call. Maybe they do something outside of, because our folks, a lot of our folks that are older communicate by phone still rather than strictly over internet. And so just, I think there might be some reassurance with that.
Okay, so I think in this, sorry.
No, go ahead.
I was going to say maybe a missing piece just at the moment is we're not quite clear on all the resources that the Council on Aging currently has or is planning to make available. We should know that, I think, sometime midweek this week. So, but again, it's a great reminder. We will look to see in their information or in their thinking right now what additional education information they are proposing for seniors, especially with regard to comfort levels around appointments, adequate PPE, assurances around safety, right, virus exposure. We'll make sure we bring that thought into this section, right? So we're addressing that. Again, maybe an opportunity to provide additional information for our healthcare community that reminds them around these sensitivities for our senior population. Again, special attention to the risk, right? The increased risk to overall health around social isolation and loneliness, and what they can do to help ease some of those concerns.
Mm-hmm.
Okay. All right, that's taken us through Roman numeral 1, 2, and 3. It sounds like we have some slight, easy to capture modifications in each of those major areas. I can't promise the turnaround on this thing, except I know that Dia is probably already working on it as we're talking through this. Mary Linden, will be waiting to hear back from you, right, by noon Wednesday for your additional feedback. We'll get a revised draft out to this council. We'll do some work, trying to quantify what we believe the cost might be associated with some of these efforts. And I think you all know well enough, we're going to do best guess, right, on these things. It's really a matter, we really want to get some placeholders out there and some realistic numbers in front of the mayor so that we can get some allocated dollars to each of these areas. Angie, Dia, what's not been covered today? Looks like we're actually going to give people 15 minutes back. Again, with an apology for the difficulties in getting this meeting launched, but with sincere and heartfelt appreciation for all the effort that has gone into getting us to where we are today with this document. Feel really good about the work that's been done, about being able to put something in front of the mayor that is still timely and critically important for the health and wellness of our community. Well, I said I would take silence as agreement and consensus. And I think unless I hear otherwise, and I'll give it to 10 seconds, we will adjourn.
Thank you, Bob. Thank you, everyone, for your teamwork.
Thank you. Yeah, thank you. Appreciate all feedback. And, you know, hearing from several of you during the week as you were looking at this draft, you know who you are. Really appreciate the phone calls and the interaction. Lots of nice modifications were made as this draft was developing, so thank you. Okay, thanks.
Thank you.
Meeting adjourned.